Hi everyone, welcome to Endocast. I am Dr. Tuğçe Apaydın and today we have an exciting episode for you coming to you live from Endobridge. I have attended a comprehensive presentation by Dr. Evangelos Chartampilas on imaging in endocrinology and we are thrilled to have him with us today. Thank you so much for joining us and thanks for accepting our invitation.
Thank you very much, Dr. Apaydın. Thank you very much.
I'd like to ask about adrenal imaging. What imaging methods should we perform first? Adrenal lesions.
Okay, adrenals are incidentally detected. An adrenal lesion is usually incidentally detected on CT or MRI because it's very difficult to see the adrenals on ultrasound, particularly the left adrenal. Even if you know there's a tumor, it's very difficult to visualize it. So we are going for CT and MRI. So you usually find a nodule, let's say a 2-centimeter nodule, on the left or right adrenal. So if it's on the CT, on the unenhanced CT, if it's less than 10 Hounsfield units, then you're sure it's adenoma and you can leave it alone. Okay, so 10 Hounsfield unit is the cutoff size to tell it's an adenoma. If it's above 10 Hounsfield unit, for example, if it's between 10 and 30 Hounsfield unit, then it may still be an adenoma. You could either perform an MRI with a chemical shift imaging sequence and detect intracytoplasmic lipid. So if there's a signal drop on the outer phase compared to the in-phase image, then again, you're sure it's an adenoma and you leave it alone. Now, things are getting more difficult if the lesion is more than 30 or 40 Hounsfield unit. Then it's very difficult to say it's an adenoma. It can still be, but more than 30 Hounsfield unit, there's no need to perform MRI because MRI will also be non-diagnostic. You will not have signal dropout. You may perform a dynamic CT, seeing that there's washout, but again, sensitivity drops. So more than 40 Hounsfield units, I think that the best approach, if the lesion is less than 4 centimeters and the patient has no clinical symptoms, there's no history of malignancy, I would suggest a follow-up CT or MRI scan in 6 to 12 months.
Thanks a lot. This is really important for us actually. I believe it will be really helpful for us since we often see the misuse of imaging methods in clinical practice.
Absolutely. For example, if there's an adenoma, an adrenal lesion that's 50 Hounsfield units and enhanced, there's no need to say do an MRI. There's no need at all, because even you won't see signal drop, that's for sure, and you should search for something alternative other than adenoma. On the other hand, if you have a lesion that is very enhancing, let's say on the post-contrast on the post-contrast phase, it is 130. Then it still cannot be an adenoma. You should look for a pheochromocytoma if it's that brightly enhancing. And also, there are always traps, even with there are pitfalls, even with the adenoma imaging or for pheochromocytoma, there are always atypical cases. So if you see something that is very brightly enhancing, even if it washes out, because the washout technique is a very sensitive one for detection of adenoma. But again, if it is, let's say, 140 post-contrast, and then it becomes, let's say it washes out, it becomes 30, this 140 is not consistent with an adenoma. And sometimes up to 30% pheochromocytomas may also show washout. So it all depends, and you should discuss the case with the radiologist for the next step, if any. If the lesion, for example, in the adenoma is less than 1 centimeter, you can leave it alone, less than 1 centimeter, because there are big series with, let's say, 2,000 cases, and the malignant ones were 0.2% out of 2,000, meaning 4 cases. So it's less than 1 centimeter, leave it alone.
Okay, thanks a lot. If you have time, I would like to ask a few questions about parathyroid imaging. Could you also mention what should we assess first to evaluate a parathyroid lesion first?
If we will go for the cross-sectional images, I'm a radiologist. I have no much experience with nuclear imaging, but from my point of view, you can use a 4D CT or 4D MRI. There are some reports saying some advantages of 4D MRI due to diffusion imaging or to the high T2 signal lesion of the adenoma. but I wouldn't depend on this. I mean, if you perform a nice 4D CT, then you can diagnose your adenoma with quite certainty. 4D CT, the fourth dimension is time. So you perform one phase pre-contrast, one phase post-contrast, arterial phase, and one delayed phase, delayed 70, 80 seconds after the contrast injection. So this is the portal vein. Adenomas typically enhance brightly than thyroid, and they become iso or hypo to thyroid, or they may enhance similarly to the thyroid, but then they wash out. So they are hypodense on the delayed phase. While on the contrary, the lymph nodes, which is your main differential diagnosis, because at the locations of the adenoma you frequently see lymph nodes tend to progressively enhance. So you can differentiate between the two. And if the lesion washes out, then it's an adenoma. If it's a progressively enhances, then it's a lymph node or sometimes an exophytic nodule from the thyroid, because it's also a differential. You have a nodule that, let's say, it's hanging from the lower pole of the thyroid. It's still thyroid.
Okay, thanks a lot. Also, I would like to ask, how should we decide in cases of discordance between sonography, scintigraphy, and 4D CT?
That is a very difficult question. I think sonography has a little role to play, because if the lesion has the typical appearances of an ovoid, kypoechoic, encapsulated with a polar artery, okay, this is fine, it's an adenoma. So the question is what modality should we choose to diagnose a parathyroid adenoma, ultrasound, 4D CT, or cystamebi? Okay, with ultrasound, first of all, you can see in the mediastinum where these parathyroid adenomas are usually, are not usually, but they may be seen as they are ectopic. So, on the other hand, the typical appearance of an adenoma is also rather rare to see on ultrasound. I mean, this well-defined hypoechoic structure behind the thyroid with a hyperechoic capsule. So we will go for 4D CT or cystamebi. Either of these can be a diagnostic or non-diagnostic. I would go more for cystamebi as it has the capacity to retain the radio tracer. However, radio tracer can also be seen in the thyroid nodules. So I think the best approach is either to do a dual phase cystamebi scan or a dual isotope by adding pertechneate technetium and cystamebi. So in single phase, you can detect which is thyroid and which is parathyroid.
Thanks a lot. Thanks a lot.
You're
Thanks
welcome.
a lot. You're sparing your time for us. Thank you. Thanks
It's
a lot.
It's a pleasure.
It was nice to having you here.
Thank you very much.
Thanks for joining us. Thank you.
Thank you, you too.
We will continue exploring important topics in endocrinology and see you next time.